Mike, thank you very much. And PK, thanks for the invitation. So let's talk a little bit about atherectomy for restenosis. Perfect cases, for this particular talk. These are my disclosures. Again, we've heard FemPop instant restenosis occur in about 30% of stented patients at 1 year and up to 49% at 2 years. PTA is essentially an outdated mode of treatment. The recurrence rate is extremely high. Patency can be as low as 28% actually at the end of 1 year. So new therapies, laser, atherectomy, Viabond, stenting, DCB have shown superiority over PTA in treating FemPop ISR. So this is some of the data on the DCB in FemPop ISR. And as you can see, in the registries, Lutonix and Impact, as well as multiple randomized trials here, very long lesions, 18.2, 17.3, 17.17 centimeter. They all look good, except for this outlier with the freeway drug-coated balloon, where your TLR rate seems to be pretty high. That's probably more of a balloon characteristic more than anything else. If you look, however, at 3 years, we actually start seeing loss of the DCB effectiveness in instant restenosis, and as we can see from the debate ISR, the TLR rate was 40% with the DCB and 43% with the PTA, essentially no difference. When you look at the total occlusions, also DCB don't do very well with instant restenosis total occlusion. You can see the freedom from TLR goes all the way down to about 50%. And again, the recurrent restenosis at 2 years can be as high as 35%. We've seen with the laser, that we have better data with lower TLR, better patency, and less bailout stenting in the Excite ISR trial. Again, these are long lesion, 19.6 centimeter, 30% occlusive, but this data is at about 6 months. That was the primary endpoint of the Excite ISR. Again, at 1 year, we see continued superiority of the laser over the balloon, but we lose a lot of grounds when it comes to patency and freedom from TLR. Again, we see the longer lesions tend to behave better, with the application of laser and angioplasty compared to just angioplasty. If we look at the Jetstream case, similar to what PK just did, this is a very frequently used device in our lab. And we know from the animal models, that it works very effectively, excised tissue very nicely, going from the blade down to the blade up mode. You gain very substantial amount of tissue removal. We know very well from the Jetstream ISR trial was a feasibility study of 32 limbs, 29 patients, looking at stent integrity and safety at 1 month and TLR at 6 months. In very complex disease, 19 centimeter lesion length, task C and D were 62%. Over 30 centimeter lesions were 25%, and CTO were 25%. 66% of those lesions have been previously treated. We see that we can achieve a residual stenosis at the end of the procedure of less than 30% and 100% of the cases. Bailout stenting was only 6.3%, and there was no stent fracture or deformities as adjudicated by a core lab. Again, no abrupt closure, acute thrombosis, perforation, or major bleeding. This is a typical results, what we see with the Jetstream ISR following Jetstream, very nice debulking, and following drug-coated balloon. Now we see however, the problem with no DCB, the Jetstream behave very much similarly to what the laser does. You get very, very good results with TLR survival at 6 months. However, a significant drop is seen at 12 months, and very much parallel what we have seen with the laser. And in fact, the patency at 6 months of 72% was almost identical to what was seen in the Excite trial, but no stent fractures and no amputation in this particular study. So how do we compare the atherectomy to the drug-coated balloon? As you can see, this is the laser, that's the Jetstream XC, and you can see these are high towers here compared to the drug-coated balloon, with the exception, of course, of the freeway that is an oddity, and as I said, is probably DCB related, the type of balloon. But you can see all the DCB, DS, and the Viabond are running in somewhere between that 10 to 20% TLR versus that 40 to 45% TLR that we see with atherectomy. So again, atherectomy alone probably not going to cut it. So the problem here is DCB is good at 1 year, loses ground after the first year, and is similar to PTA at 3 years. Atherectomy is better than PTA, but not as good as DCB at 1 year. How can we extend the effectiveness of DCB DCB beyond the first year. We know that the morphology of ISR, a lot of hydrated collagen matrix, watery sponge, 60 to 80% of neo-intimal hyperplasia, and we know the balloon alone, works by compression and decompression, pretty much the main mechanism for early lumen loss. So PTA provides good acute intrastent luminal gain. However, half an hour delay, and you come back and revisit the lesion that you treat, and you see that your intrastent volume has increased by 32%. So again, we have a lot of intrastent thrombus in ISR, particularly in late ISR over 1 year, as was presented at LINC 2018. Very interesting data, and we know very well that thrombus, have a very high affinity to paclitaxel. In fact, red blood cell retain 50% more paclitaxel than pure fibrin clot. So the strategy of removing the thrombus or modifying its presence may very well be an important strategy to enhance drug elution, and we know very well that laser and jet stream both have the ability to remove thrombus. So again, this is a combination therapy, well-coded trial from Gandini in patients with chronic SFA instant occlusion in CLI patients, so very high-risk population, and you can see that the cumulative patency for the combination therapy of laser and DCB was quite better than DCB alone. TLR at 12 months was 16.7% with the combination treatment versus 50% with the DCB only. Also, we know from data just presented also at LINC by Vandenberg, showing in 25 patients that the long term is very good. In fact, at 3 years, freedom from TLR was 76.4% with combination treatment. And we also have had some recent data from the laser and DCB from Armstrong Lab, showing that in CLI, 33% patient, 2/3 are total occlusion, and you can see freedom from reocclusion is about 86.7% with the combination treatment, and freedom from TLR is about 72.5% for these very complex disease. Again, atherectomy is more effective than PTA in treating FEMPOP ISR and long lesions, high procedural and device success, no stent device interaction. TLR rate and patency with DCB and Viabon appears superior to atherectomy in the first year. However, DCB starts to lose effectiveness after the first year and is less effective in ISR total occlusions. And combining atherectomy with DCB in treating FEMPOP ISR appears to be a promising strategy, but we need larger randomized trial of atherectomy plus DCB versus DCB in FEMPOP ISR. Thank you very much.